So welcome back to Creating Careers Moving On with the NHS. Just to remind you all of our housekeeping rules, cameras and mics are all off automatically. Please ask any questions you have via the chat box and ask as many questions as you'd like to. I'll just hand over now to Sharon Moorcroft, who will introduce the session. Thank you. Thanks, Sharon.
Hi, welcome back everyone. Apologies for Adam Town before, but I'd now like to introduce you to our podiatrist, Lindsay Berry. Thank you, Lindsay.
Hi everyone. I'm coming through the speakers okay, aren't I?
You are, yes.
Okay. I'm still all quite new to all this Zoom, believe it or not. Yeah. I will just share my little presentation now. And then I'll just give you a little introduction to where I work and who I am, basically. Share screen. Here we are. Oh, host is disabled participant screen.
Oh, sorry, I'll just make sure that's on.
That's okay. Don't worry. Should work now, maybe. Oh, no.
You should be able to share now. Sorry, Lindsay, I think it's
okay, don't worry.
Before.
Thanks.
Don't worry. Oh, here we go. Right, now. Let's try and find this. This is where I feel like you show your age when it comes to technology. Sorry, just bear with me. I'm just trying my best to find it. I have it sitting here, but I don't know how and why I can't seem to find it.
So I don't know whether you can multitask at the moment while you're looking for that. Some students wouldn't know what a podiatrist does.
Yeah, so podiatry, probably a lot of people are a lot more familiar with the term chiropody or chiropodist. And it's the study and the working with the ankle, the knee and the hip and how they all work in relation to one another. The job itself, we see all different age ranges and, you know, right from babies right up until elderly. We see people with sports injuries, we see people who might have physiotherapy problems. You know, that the age and the variety of our patients is so varied. We also work within community settings, within GP surgeries, we do home visits, we go into nursing care, we do things like this, we promote the service. And it's all about, you know, educating the public on what we do and how important feet are and how important foot health is, because I think a lot of people think feet, ooh, you know. So it's trying to get that stigma out of the way, really, and make people think podiatry could be a good career for me. I am so sorry. Right. I have it sitting right here. I just can't seem to. Sharon, if I email it to you, is it something that maybe you could put on the screen for me? Is that a possibility?
Sharon's on mute.
Oh, is she? Oh, sorry.
No.
Sorry, I sneezed, so I put myself on mute. Yeah, I can have a go. Yeah.
I'm just having a bit of a brain blank here, really. I will send it to you now. Apologies for this.
Shall we ask you some questions in the meantime, Lindsay?
Yeah, no problem.
Does it take a long time to train for your profession?
So it's 3 years, the same, you know, as all the AHPs, radiography, physio, the same length of time.
And is that a degree course you do?
It is, yeah. It's a degree year BSc, and there are 9 colleges at the moment, or 9 universities who offer the course. So, I mean, it's science is obviously the big one. There is some chemistry involved, physics, all the elements of science really come into play really with it.
So the usual route would be through A levels to university?
Yeah, it would be A levels, or I actually went to college after I finished. I originally started a social work degree, and it wasn't for me. Did 2 years, and that was enough for me. And then I went back to college and done what's called a health sciences diploma, and then that opened up the door for me if I wanted to do nursing, physio, radiography, optometry. It was just so varied, and I didn't quite know what I wanted to do at that time. So what I did, I went and shadowed a couple of different AHPs, and I shadowed this fantastic podiatrist, and I was kind of a bit like, oh, feet, but when I met her and I was with her and I seen what she did and like the big impact that it makes to people, I thought that's for me. That's really something I could do. And just the opportunities that come with it. I've got a few friends working and living in Singapore, in Australia. Just I've got a couple of friends opened up a private clinic recently, left the NHS, and they're doing fantastic. If someone wants to work for themselves as opposed to working for the NHS, that option is there too. So just, yeah, I love it. Really do love it.
And what's your favourite part of your job?
I like seeing the little babies and the children and, making a real difference for them. That's what I like a lot. I mean, who doesn't love a little baby coming in, and that is nice, little baby coming in and mum's distressed, doesn't know what to do. GP obviously isn't quite sure, so they send them to us, and then it's all about, reassuring mum, making sure baby's okay, giving them all the advice to, look after themselves. And it's nice because you're giving them all that information that they're going to carry through until, child's able to manage themselves, so it's nice, you make a real impact. And it doesn't feel, sometimes in NHS, a job can feel very much, one in, one out, and we get quite a lot of allocated time, and you get to know your patients, especially ones that do come back, and you do build relationships with them. When I'm off to have my baby, I mean, there's little patients bringing a little cars, little chocolates, wishing me well. And I mean, you get to know your patients. Sometimes in other AHPs, it's, hello, I know you for 6 weeks, and then, you're on your road to recovery, which is nice, but it is just nice, getting to know your patient base and getting to know them. It's like having little grannies and granddads everywhere, it is nice.
And what's the most rewarding part of your job, would you say?
So for me, the job satisfaction comes from when a patient sits in the chair. I mean, it might just be a little 96-year-old that can't reach their feet and can't cut their toenails, and there's absolutely nothing wrong with their toenails, just straightforward, 5 minutes. Anyone could do it, but the difference that makes to little 96-year-old Betty, it means that she can put on her shoes, she can go on, and, you're reducing the risk of her falling, she can go to the hairdresser, she can do, live an independent life. I think that's what really I like, 5 minutes and you've made a difference to someone in ways that you don't even realise. That's the job satisfaction for me.
And a lot of people say working for the NHS or in health is really a calling. Did you feel that?
Oh yeah, definitely. The difficulty was for me, my calling was in the social side of care first, as opposed to the health. I knew I wanted to work with people. I've always been a people person. I've always loved working with people, loved chatting, as you probably gather by now. And and as I say, for me personally, if you're not sure what you want to do, that's absolutely fine. Just try and choose something maybe in college, or try and choose your A levels where you're not putting yourself down a specific route, where you are open and you can change your mind. And I would try and shadow as many AHPs. I mean, for me, I was considering optometry, physiotherapy. I considered more or less them all. It didn't have one that was leaning towards me until I actually went and shadowed them and spoke to a couple of people, seen the job satisfaction, you know, even simple perks that you won't think of. I mean, it's Monday to Friday, 8:30 till 4:30, all the weekends off, you know, small things like that you don't
Yeah.
when you're younger, but when you're my age, you know, you do think, oh, that's great, you know, I've got a weekend off, I've got my bank holidays off, I don't work Christmas. All those little things really do make a difference, and they really did help steer me in the direction of choosing podiatry.
So a couple of people have asked, so is it usual for you to work those kind of similar hours all every week, or do people work shifts?
In the hospital, I do believe that there is a bit more of a shift works option, if that's what, you know, but it is, I mean, my hours are Monday to Thursday. I don't actually work Fridays, Monday to Thursday, 8:30 till 4:30. And that's it. As soon as I do my job, I don't open my laptop and have to worry about it once I leave on a Thursday. That's it. You know, there's no more. And that's why I did change my mind from social work to podiatry. I realized, you know, for me personally, I didn't want to open up my laptop at home. I wanted for my home time to be my home time and my work time to be work time.
Yeah, and that's something students really need to consider, isn't it? You know, the working hours and that work-life balance.
Yeah, totally. I mean, you know, when you're 16, 15, you know, you really don't think of things like that. And it might seem odd me telling students things like that, you know, but I think it's something to consider, you know. If you want, I mean, I can just decide, oh, I'll go for a long weekend to the lakes and I can do it. I don't have to think, am I working that weekend? You know, can I do that weekend? You know, because I just have the weekends off, you know.
That's great. Now, Sharon's managed to get your presentation up, so hopefully between the two of you showing a bit of teamwork here, present to us.
Lovely. So I apologize in advance. It might seem a bit deaf by PowerPoint. I try and be as interactive as I can, given COVID and everything going on, but I will try and make it as interesting. But if there's any questions at any point, please ask, please stop me, because I might not actually see them popping up, but I'll start now, okay? So as you know, I'm Lindsay Berry. I've been a podiatrist now for 8 years, I think, 9 years coming up. And as you've probably gathered, I absolutely love it. So I'm going to try and sell it to you and make you become a podiatrist. Right. Now, can you on for me, Sharon? I'm sitting there thinking, thank you. So yeah, what is podiatry? So that I'll give you another synopsis now, basically on what it is I do and what podiatry would entail for you if you were to choose podiatry as a career. Thanks. So yeah, it's so much more than just cutting toenails. I mean, that will be the majority of what we do some days we won't do any of that at all. But as I said earlier, it's a study of the hip, right from the hip to the toes and everything in between, how they all function as one. And as I say, we specialize in musculoskeletal function of the lower limb. So any lower limb issues at all, we are the 4-foot runners in that, really, and we take over and manage that, diagnose any problems, and come up with any management plans. So we are also equipped to diagnose, to help manage skin conditions, so basic dermatology things, we're able to diagnose. We're autonomous in that way. Circulation problems, which is massive at the moment as well. You probably all heard about amputations and things like that, smoking and things. We're a big player in that as well, and autoimmune conditions as well, and just about anything you can think of with feet, we are the go-to person. That's our little expertise. You've probably heard people say you can tell a lot from your eyes about your health. You can also tell a lot about someone's health from their feet as well. So we can be sometimes the first to point out serious things that can be lurking in the background of people's health. And we can be the person that signposts you to your GP to diagnose things that we see with your feet. So what does a podiatrist do? Thank you. So people who do have problems with their feet are quite anxious about it and will actually sit on that problem for years and years. And sometimes we don't see people 3 years and they've had a problem, which is quite sad, really. But again, I think it's the stigma around feet, and we're not a society who like to get our feet out. If you like, in Australia, you know, they're mad about feet out there, and As a podiatrist, we use our expertise to try and support these people and, as I said, enable them to live more mobile lives, and obviously try and reduce falls and things like that in the elderly population, definitely. So if you were to become a podiatrist, you would see patients, as I said, children with lower limb problems or problems walking, people with diabetes is massive again, circulation problems, and who may be at risk of amputation, which is scarily becoming quite common. People with sports injuries, dancers, people who put stress on their feet by spending long hours on their feet. Those are the kind of patients that we would be seeing. We are very autonomous in terms of we can diagnose, we can do treatment plans, and we can take control of certain situations and manage it with between ourselves and the patient. But there are other times where we do need to tap physios, dietitians, GPs and nurses for more of their expertise. If we felt like we needed a physio to help with strengthening exercises, we would also tap into their their reserves as well and share the patient. But as a podiatrist, you can work in hospitals, community clinics, patients' houses, GP surgeries, pretty much in any of those situations. Thank you. Can you pop that on? Thank you very much. So I think the question is do you think it could be a good career for you? The things that I'd be thinking, you need to ask yourself, do you enjoy working with people of all different ages? As I say, can you communicate with a frantic mother with a little baby, and then 96-year-old Doris, can you see yourself working with that lovely variety of ages and everything in between? Are you looking for a rewarding career with a really high job satisfaction? You do need good communication skills. So, do you have them? Are you willing to work as a team? Are you empathetic and caring as well? Obviously, you have to have those qualities for any NHS role, have an interest in science and pharmacology. That's a big one. We do quite a lot around pharmacology, and I'll explain that in a little bit. Interest in problem solving, investigation. As I said earlier, you are the foot expert, if you like. You're getting a GP for your, a referral from a GP for your opinion. They don't know what the issue is. So can you work it out? Can you solve the problem? You are kind of like the last line in the defense, if you like, to try and sort out the problem. So can you cope with that as well? That's another thing. Do you like, putting on your thinking hat? And yeah, are you interested working on your own and then also working within a team? So that's an element of the job I quite like. I quite like getting my list for the day, planning the visits, going out and seeing all my little people, and then also, getting the phone call, Linz, I need you here, come and help me. Can we do this as a team? I like, the variety of both as well. And then also, is podiatry for you? A big one is, do you want to keep your options open for the future as a podiatrist? You are equipped to work within the NHS, set up private practice, which I mentioned. You can work for sports teams, and you can travel to other countries and practice. The countries we can practice in the moment are Singapore, Australia and Canada. If you wanted to practice in America, it does include a bit more training, a couple of more years. It's a doctorate out there, so it'd be, you train to become a doctor to be a podiatrist in America. It's slightly different to here. That's the only country you'd need further top, but yeah, plenty of options. Next slide, please. So that's basically how you become a podiatrist. It's a degree course, 3 years full time. I think they still do the option for part-time. I think it's 4, but 3 years full time. That information, so 15 universities, or 9 at the moment, who are doing the course. Once you've successfully completed, you'll need to register with the HCPC like any other AHP. That's just to, ensure that you're registered for the safety of the public. And those are the entry requirements as well that I was discussing earlier. I did the HND, which was health sciences. As I say, it just kept my options open. Probably something that, if you're not quite sure, would be a good idea, or just your generic sciences as well, just to keep the door open for other opportunities. Thank you. I can see loads of little chats coming up, and I'm wondering, is people asking questions and I'm just whipping on through? Is there some questions? Let me have a little look. Oh, right. That's great.
Yeah, there's some questions coming through. Didn't know whether you wanted to do the presentation and then answer questions, or do you want us to look?
Is that okay? Should we do that and then
Absolutely fine. Yeah, great.
Lovely. So this little slide here, there is now apprenticeships, which are something that are quite new, something that I am not overly familiar with, because obviously being an NHS member of staff, I believe it's, if you approach a private practitioner, they will sponsor you and pay you a salary alongside training as well and support you within that, just like another apprenticeship. It's something that I'm not overly familiar with, so I don't want to give too much information about it. But anything that I have, any information there that I have, is actually off the HCPC website, so that is accurate, that is what it entails. Personally, probably better going on the NHS route, because you do get funding, you do get help, and that would probably be a better way to go about becoming a podiatrist, in my opinion, but it's there anyway. Next slide, please. Thank you. And then again, so this is something, if you do go the BSc route, which is going to university, there are funds there, the same as there will be for physio, nursing, all the other AHPs and things. There is support there, so it's just making you aware that you do get help in terms of your accommodation, actually paying for the fees as well. Right. Thank you. Right, so this, when you qualify, this is basically the kind of things that you would be doing before you become specialised and you decide what you want to do. Very important, this kind of stuff, because the routine stuff, we always say, if we look after that, it keeps the big problems away. So the routine work involves giving out advice on people how to look after the feet, what types of shoes to wear, which is so simple, but you would be amazed at the difference that it makes. Podiatrists also treat the day-to-day problems such as toenail problems, thickened toenails, fungal nails, ingrown toenails, which some of you may have had, very common in teenagers, and we correct and remove them as well. Corns and calluses, verrucas, athlete's foot, dry cracked heels, flat feet, bunions, heel pain, blisters, anything you can think of. That list could go on for days. Anything you think of for feet, we are involved in. To the right of the screen, this is checking blood flow and checking the quality of the blood flow in the legs and things. So that's another thing that we commonly do as well, which it would be considered routine, but these can these early interventions can really stop the bigger things developing, and amputations and things like that. So that's just a little picture of some equipment, the kind of equipment that we use day to day as well. So I'm sure one of you, all of you, or I'd be surprised if none of you don't know anyone with diabetes, and the impact of diabetes and the feet is just so important for diabetics to look after their feet. The cost that it costs us as a society. So we are massive in preventing any problems with diabetes, as you can see here on the screen. The complications are amputation, which we are just so important in trying to reduce the amputation numbers in the UK at the moment. Blindness, kidney failure, stroke. That's when we tap in with all the other services, the specialist diabetes nurses, the dietitians. That's where we really all come to play as one big team, if you like, to try and look after each little section. In ours is the amputation, checking the blood flow, educating them on what to do, the do's and the don'ts, having them in on a regular basis, checking, making sure everything's okay, and that's just so important. That's why podiatrists we need more podiatrists. That's such a big thing. So see if we have any information on that, Sharon, so I can elaborate a little bit, please.
I don't want to click too many times.
Okay, don't worry.
Is that okay?
Yeah, that's perfect. So diabetes causes nerve damage, which if it's uncontrolled, it can lead to a thing called peripheral neuropathy. And this is when people can't actually feel their feet. They have no feeling at all where their feet are. If they close their eyes, and they would have no, what we call proprioception. They have no awareness of their feet. So the unfortunate thing for people who have this condition is they stand on something, they have absolutely no idea that they've done it. So the ulceration risk is high. They could break their skin, have quite a nasty hole in their foot, if you like, and not be aware of it. So this is where, again, we come into play, educating and making sure the families and family members support them, checking their feet every day, getting a little mirror, having a little look themselves, coming in to see us, we can check them. Just little things like that, as I say, that just really make the difference. Obviously, when they do have an ulcer, we would heal them, dress them, check their blood flow, you know, and just really manage that in the community, get antibiotics, refer them to vascular if they need surgery. Yeah, just such a crucial service, really, our service when it comes to diabetes and their foot care. Okay, and again, diabetes affects circulation. Poor circulation can affect how the body heals as well. And people with diabetes, sadly, are more prone to infection. And that's very common, we see that. Yeah, we've touched on that. Thank you. Thank you. This is an area, again, another general area, but it's something that you can move on and specialize in as well if it's, you know, what you like. This is really about people walking, how they walk, their walking patterns, how it affects their hips, their knees, and their feet as well. So any abnormality, any walking pattern that we wouldn't class as normal, or if someone was getting a lot of pain from it, they would see our musculoskeletal podiatrist, who would try and diagnose that problem and try and give them a prescription orthotic. If that didn't work, again, it would be tapping in with physio and together with them to try and best manage and give them a better quality of life. Also, people who've had injuries, sports injuries, anything like that, they'll get referred to us as well, and we'll try and help them work through that problem as well. Seeing these questions pop up now, sorry, I will answer the questions at the end. And sports rehab, again, is another area of specialties, not so much in the NHS. This is very, very much private, around the private avenue. If you were employed by a sports club or a sports team, you would work with the physiotherapists really closely on this. You can see this little area here where this lady's having what we call a biomechanical assessment. It's recording someone very slow time running, actually seeing how the foot hits the ground, how that reacts, how the knee joint works, what angle everything works at. These are just massive things within the private sector. I mean, Liverpool football team have their own designated podiatrist who will predominantly just do this all day in terms of making sure everything's on point, try and prevent any injuries, because obviously injured footballers cost clubs big money. But yeah, so this is a massive, more a private area. We touch on this slightly, but if you were interested in becoming a podiatrist and you wanted to work privately, this is a massive area for private podiatrists. Rugby teams, cricket teams, any sports team, they will have a designated podiatrist who'll do all this. Thank you. So this is in the NHS area, big NHS area for teenagers. I don't know, some of you might have had some kind of experience with this, certainly, ingrown toenails. This is one of my favorite parts of podiatry. Teenagers coming in, problem with cutting their nails too short, shoes too tight, playing loads of sports, and then they've got a big, horrible, nasty ingrown toenail. So I love the fact that we can just take ownership of that and just sort that out for them and just give them back that lease of life that they need, really. You know, this really impacts people's quality of life. So we do a minor surgical procedure, which is pretty cool, I think. You know, inject local anesthetic in toes, completely numb the toe, and then remove the part of nail that's causing the problem. That is, yeah, one of my favorite things to do. Call them back 3 days later, tell them the do's and the don'ts, how to look after it, and then, you know, keep an eye on them for 2-3 months, and then they're healed, and then they're back to a normal life, then back to playing sports, back to not taking antibiotics. And yeah, that's one of my favorite parts of podiatry, definitely. Another thing to consider if that's the kind of thing you would like to do, little minor surgical procedures. I think I've covered that. Thank you. And there is some postgraduate options as well. Becoming a surgeon So doing corrective surgery, which is more invasive, people actually going to sleep, that is an option as well. So it would be reconstructing bones in the feet, removing bunions. There's fractures in the feet as well. It would be correcting all them as well. That is something that postgraduate, if you decide that you're not doing enough with all the stuff I've gone over, you can go and become a surgeon. Forensic podiatry as well is something that's quite big, becoming quite big in the UK, and they assist in the crime scenes and court cases, which actually is quite quite a big thing. That is the only thing that's left behind usually at crime scenes. So it would be predominantly, trying to work out what type of person it would be, what type of shoe it was, what weight they would be. It's just such a massive area of podiatry, and that is another option post-grad as well that you can do. You can specialise in that after you've done your 3 years training, if that's something that you're interested in. Thank you. So why did I become a podiatrist? I think I've really covered that, but see if there's anything that I haven't covered. Yeah, I wanted to work within the, I actually had my job. I was 2 years in the training, 2 years of my training, and I had my job waiting for me before I even qualified. That's how in demand we are. The diabetes and everything else going on. It's not the most popular or glamorous AHP role, so I think that's probably a reason why as well, but great for me, knew I was going to be walking into a job, so that was perfect. High demand for, as I said, podiatrists with diabetes on the increase, the social working hours, which I love, and in the future I have the ability to set up my own private practice, which I will look into in the future. And then obviously, if I pack up tomorrow, I can go and work in Singapore, Canada, Australia, New Zealand, and most importantly, it is a really rewarding job. Love it, I really do. And there we go. Right, so there are a lot of questions. So I'm going to click on, and I'm just going to go right to the top. All right, and then I'll come down. Please type any questions. So the question about the voluntary work and what I recommended, how to volunteer. So shadowing a podiatrist would be something, if you were considering I would recommend you do it. I can certainly pass on Sharon my contact details. That's something that I think our trust would be more than happy to facilitate if someone wanted to come in and shadow us for half a day, a portion of the day, just to see what we do. It's quite difficult to visualize it. I think I suppose it's really putting yourself in that environment where you see the interaction, you see the job, and then you really get a feel for it. That's what inspired me to become a podiatrist. So definitely that's something that we can facilitate. Do you have to continue to study once qualified? Yeah, it's a continuous process. To be any healthcare professional, it is your duty almost to make sure that you're up to date with all the current research, current studies, the current guidelines, any AHP that you decide to career that you decide to do, or any nursing that you decide to do. That is a requirement of you, no matter what you decide to do. You will be expected to be familiar with all the latest research. It's just to make sure that you're given the best quality care that you can possibly give to your patients. Okay. Oh, my mic was going, sorry. Top 3 skills, definitely to be adaptable, because and you need to work under pressure. If you're on your own and in this situation, you have to be a calm, chill person. Okay, let's sort this out, let's diagnose this, let's do this. So that would be a really important skill to have. And a good communicator, you have to be able to adapt your communication skills, as I say, to suit a wide variety of people. You could be talking to a GP, the next minute you could be talking to a 5-year-old. It's all about being able to change your communication style, and you're communicating as well. Are there opportunities to specialize? Yeah. So I specialize in wound care and looking after the diabetes side. So there are opportunities within podiatry to specialize, and then, as I mentioned, you can go on and do post-grad. You can do surgery as a full-time degree, and then you can do forensic podiatry. There's obviously masters that you can specialize in. That's also an option. Lovely, thank you for that little link, Julie. That's great. And NHS careers is a good starting point, yeah. Where do you see myself in 5 years' time? Probably making steps to having a private practice. I do really enjoy NHS, I really do, but I think it's the flexibility that comes with the private practice that's tempting for me, really. So fingers crossed, part-time NHS, part-time private practice, but we'll see. I might still be in front of you guys in 5 years' time saying the same thing. But I love it anyway, no matter what I do. Do you do preventative work with schools? Not as much as I would like to do, really. But that's something that, you know, I'd certainly be open to in the future. I like doing these things because obviously it gets podiatry on the map and people know what podiatry is and people know that it's not just cutting toenails, and you know, so that's what we do at the moment in terms of schools. And then do you work with OTs and physio? Yeah, we do. In our building, actually, we have OTs with us in the building, which is really good. So we bounce off ideas to each other and we talk about patients together, and what do you think about this? Should we do this? And again, physios as well, really work really closely with them. We bounce back patients back and forward to one another as well, which is really good. And then what prompted you to choose this career? I seen a podiatrist in action and that was me. I loved it, absolutely loved it. And then what's the salary? So I'm a band 6 podiatrist, so it just depends on how long you get a yearly increment. So every year you get an extra, I think, £1,000. So band 6, same as any other nursing salary. Entry is band 5, so 22,000, I think. And then it can go right up to band 8, which is 45. So it just depends on experience and how long you've been in service. You have a role model or mentor. So I have, so I was saying, you come in as a band 5, then you become a band 6 specialist, and a band 7 would be your team leader and things. So my band 7 would be anyone who I run things by the newly qualified people too, because they're a lot more fresh than me. So that's quite nice. You know, it's a case of everyone brings something to the team, which is nice. And then is there much opportunity for promotion? Yeah, there is. I was really lucky in terms of a job came up 16 months after I qualified, a senior role, and I got it, and I'm still doing it now. And there's hopefully some more coming in the pipeline, which I'll throw my hat in for. Do you need to be? Yeah, so you need to pay £90 a year. You have to be on their register. That again is to prove that you're safe for public practice, and it's optional to be a member of the society, which is private insurance. So you don't have to be a member of that, but we recommend that you are, just for your own benefit. And they also provide you with CPD, which is the thing I was telling you about earlier, the training that you need to continue professional development. So you do pay them a fee. But they support you, and they in turn help you with, you get a monthly magazine, all the latest studies that are being done, all free training online, just to keep yourself up to date. So it is worth it. It's expensive, but for what you get in return, it saves you going and looking for all your information. So it is worth it. Yeah, anything else? No? Yeah, so I don't go into the hospital at the moment because I'm community based, but with my job and with the qualifications that I have, if the job came up in the hospital tomorrow, there's no reason why I wouldn't be able to transfer those skills and work in the hospital setting. Our colleagues do work in the hospital, we liaise with them. Anyone going into hospital, can you keep an eye on Mr. Smith on such and such ward, and vice versa. They come out, can you go and check them? So it is transferable. Or work in the community. Yes, so I work in the community at the moment. Yeah, and COVID did alter the way we worked in terms of, I think like everyone at the beginning, we just didn't know what we were working with. We kind of shut the doors for 4 weeks, at the very beginning, only seeing people who were absolutely, if we didn't see them, they would end up in hospital. So those kind of high risk patients, the diabetes, the patients with really nasty ulcers, anyone like that were the only people we were seeing. Everyone else was put on the back burner until we got to grips a bit more with COVID, what was going on, PPE, social distance. Once all those kind of started coming back in, we opened the doors again, and we're just seeing people routinely now as we did before. We're able to work from home, which is absolutely great. You know, we've all been provided with our own laptop after we've done our visits on our list, come home, sit in the garden, do your notes, do a couple of things, stay online till 4:30, and that's great. I don't miss that office environment too much, but it's nice to see them every now and again. But that's the big change at the moment with COVID. Staying at home where we can. Anything else? No?
I think that's all the questions for you, and perfect timing, really, Lindsay.
Yeah.
Wow, well, there you go then.
That was fantastic. Thank you so
thank
much.
you. Oh,
And
you're
I
very
learned
welcome.
quite a lot there.
Yeah, I mean, yeah, I feel like it's a bit death by PowerPoint, but everything is in these times, unfortunately.
Well,
So,
we're all learning to use these systems a lot better now, aren't we? So we're used to them.
definitely. Well, thank you for coming to my rescue, Sharon, because I don't know.
Oh, you're welcome.
I just couldn't see it, and I'm thinking, I'm looking at it and I just can't see it. But we got there in the end. Thank you for
We
being my
did.
lovely assistant.
And thank you for your time.
Oh no, you're very welcome. Thank you very much. And I say, if Sharon, and if anyone needs my contact details, just anyone wants to know a bit more, doesn't want to put it in the chat or anything, just let me know. Pass on my details, not a problem.
Yeah.
Thanks so much, Lindsay.
Not a problem. Nice to meet you. Take care
And
now.
you too. Bye.
Bye.
Thank you.
Bye.
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 So Sharon, we've now got Jo Horton,
Yes, that's right.
radiographer.
Yeah.
I'm just looking to see if Jo's with us. Oh yeah, we've got
Yeah,
Jo
she is.
here. That's great. So shall we go on to the next presentation? Is that okay?
Yes, please.
Yeah,
Hi,
that's
Jo.
fine. Hi, you okay?
Yeah, I'm fine, thank you.
Can you hear us all right? Jade
Yeah.
is with me as well, Jade Wood.
Hello.
So, yeah.
Great.
So
Thanks
we've
for
got
coming.
a short presentation for at the end, if that's okay.
Yeah.
Fantastic. Thanks a lot.
Let us know when you're ready to start. Oh,
Yeah, we're ready, Jo. Yeah.
okay. Hello, everyone. Can everyone hear? Any questions you've got, pop in the chat and we'll answer them as we go along or at the very end. So my name's Jo Horton and my colleague's name is Jade Wood. Okay, and we are both diagnostic radiographers. Okay, so a bit of background. Radiographers produce images of people's bodies. So we diagnose injuries such as broken bones, and we look at disease and pathology, and this helps to understand what's happening to people and why. We look after people who are unwell or in pain. Some patients, when they present to us, might be angry or they might be upset, and they might also be worried. They may also be really, really anxious. But what's happening to them and why, and the reasons that they've had to come to the hospital. So it's our job to help them, and caring for patients is at the heart of what we do. So we produce X-ray images of areas of interest that doctors request in order to see what is going on and why. So patients present with lots of different things. They may have shortness of breath, they may have broken bones, they might have some sort of investigation that's required in order to see what's wrong with them, and they've come from a GP. It really, really varies when we see patients. Lots of different reasons for presenting, and then it's up to us to look at the clinical information that the doctors will send with the patient, see what is best for them X-ray wise, and take it from there. So caring for patients is at the heart of what we do. So we think, it's really important to have good communication skills, because you will be talking to people of all ages, from all backgrounds. So as Lindsay had said previously, from time to time, you might be a patient may have presented and they think they've come for a chest x-ray, but actually they've got a sore foot. So you need to phone the doctor and say, right, this patient has come today. You've said they've got a bad chest, but they're telling us they've got a sore foot. So you need to phone the GP and gain clinical information in order to make sure that the patient gets what they need at the time that they need it. You might also be talking to a surgeon when you go to theatre alongside them, to see so the patient needs to see the area of interest, what they're doing and why, and you may need to adapt what you're doing in order to assist the doctor, and look at what's going on and get the best for the patient and also for the doctor so they can diagnose everything that's going on. So we use a really wide range of skills that we have to help to treat patients. So it's very important to be really, really caring. You also need to be quite patient. Patients present to might be deaf, they might be elderly, they may not communicate well, they might be frightened. You have to be patient focused, and also you need to be a good listener. So it's important when patients come, you take the time to ask them about themselves, why they've come to see you today, what the doctor has said to them, and the reason that they've come to see you, and also what they feel is going on and what's the matter, and then tell them how we can help them. So it's important that you treat people as you'd like to be treated yourself. We do our very best to look after everyone that we see. And what's important to remember is that, it's the person that we see in the hospital, in a community clinic, in A&E, via the GP, up in the theatre, even when they've been put to sleep, that it's someone's mum, someone's dad, someone's brother, sister, auntie, uncle. It's someone who is really, really important. So it's up to us to do our best to help them. And also what we need to remember, what's really, really important is that the images that we produce by the modalities we're working will help the doctors and specialists that the patient is going to see how to best treat the patient's injuries and illness, how diagnosis will help, and what their pathway for treatment and care will be moving forward. Okay. So when you study to become a radiographer, you'll develop the skills that you have in order for you to provide excellent patient care. At university, you learn things about like anatomy, physiology, pathology and disease, bony injury. You also look at radiographic technique and practice. So that shows you what to x-ray, why and how. And also technology, because technology moves very quickly and it is changing all the time. So I can tell you a tiny bit about the history of x-rays. So x-rays are a type of radiation that look into and look at your body. So the x-rays are released from a machine when we press the button, when we know that the patient is in the right place and we've got the right area of interest that's covered. And so the photons that are released are photons of energy. So they are absorbed at different rates by the body. And then it's this pattern once released that creates an X-ray image, because the body absorbs those photons at different rates. So a tiny bit of history. X-rays were discovered back in 1895 when Willem Röntgen took a picture of his wife's hand, which clearly showed her bones and the rings that she was wearing. At the very end, we've got a really short presentation to show you, and you'll see the very, very first X-ray ever in this picture. So working life of a radiographer. Okay, so we are frontline workers, and so patients are the first, so we are the first people that patients will present to once they come to hospital, so, or even via a GP, so they might have seen a doctor, and the doctor will say, what's the matter and why have you come today? They'll explain their situation, and then the patient will come to us. What's important to remember, Lindsay was talking about working and it's kind of 8:30 till 4 or 8 till 5. We work in a hospital, so hospitals are open 365 days of the year, 24 hours a day. We don't close, but we are always on hand to help patients when they come to hospital. That's really important for people to know. So if people think that they're going to be working, I mean, there are opportunities to work part-time, but this is a full-time job. There are also shifts that we do, long days. You know, I'm making it sound a bit doom and gloom. You cannot, you know, there are days off and there are weekends off, but ultimately what you need to remember that it is, the hospital is open 24 hours a day, and it's open every single day of the year. We don't close at Christmas or Easter, bank holidays, we're always open. Okay, so as radiographers, we use advanced technology to look inside people's bodies, and the images that we produce help to understand causes of illness or disease, and they look at things like fractures and people have fallen, what's happened and why. So what's important to remember is that the images that we also produce will help our medical colleagues to diagnose these injuries and conditions, and that will also help to assist with the treatment plans and the care and pathways for patients. Okay, so the role of radiographer is very important. And as I said earlier, we are the key people that people will see at the very start of the patient's journey. And it's us that helps to diagnose what is wrong with them.
One thing to remember is that radiation cannot just be given. We are bound by lots of laws in our role because obviously radiation can be bad if you get a lot of it. So there's lots of different laws that we have to abide to. So you've got your regulations and your IRR, which all point to how much radiation a person can have. So we can't just do a hand x-ray because the doctor says that they want a hand x-ray. They have to give us a reason. So as part of your job, you have to be able to question what is asked of you. You need to have the confidence to trust in yourself that if this patient comes in and says that their finger is sore, but the doctor has asked for the hand, the finger, the wrist, and the elbow, but the patient is saying it's only the finger, you need to make sure that you only do the amount of x-rays that will show what is the problem. We can't just go x-raying a whole body. So there needs to be reasons and justification as to why we take the x-ray. So it's a very rewarding role. It is very patient-centered, like Joe said, but we're also bound by a lot of laws that we have to learn and follow.
Okay, so the work that we do is really, really varied, and that's what makes it really, really enjoyable. No one knows what's going to happen. And so what you think might happen or what you might be doing during the day can change very, very quickly. Lots of patients work or will pass through the department, and it's our job to help them the best way we can, depending on the area that we're working in. So say, for instance, today I'm working in A&E. So patients come in with a lot of different problems. You know, there are patients who, you know, come in, they might be querying they have a COVID infection. Patients might come in. What's really, really common at the moment is the scooters that you see everywhere around town. There are an awful lot of people falling off those, hurting their ankles, hurting their feet. So we might be looking at something like that. We might be looking at, you know, chest x-rays because the patient has been unwell for a little while and they become short of breath when they're at rest. What we do is so varied. I mean, that does keep it really, really interesting because nobody knows what's coming through the door and nobody knows what's going to happen. You have absolutely no idea. You know, you open the door and absolutely everyone we see, it can be a different body part and could be a different problem. It could be something that's long-standing that they've not been to the GP with, or it can be something that's long-standing that they've only just managed to get an appointment for a GP with. It's really, really varied. Here in our hospital, we see children only occasionally. Sometimes youngsters come here because they've had an accident. It doesn't matter where it is, but they come here. They may need stabilisation before they're moved on to a paediatric hospital. Some of us work in community as part of our jobs. And sometimes in community, there are paediatric centres that are attached to radiography departments, so you will have the opportunity to look at and to x-ray children We find those are often injuries that occur in school. You know, they were running and they've fallen over, they've had a basketball injury, or football injuries are quite common with school children, or, you know, little ones bouncing on beds at home and they fall off, or jumping off the couch and things like that. But just to reiterate that within our department, it's our job to do our best to help everyone. It doesn't matter where you're working. It's really, really important to have a compassionate approach, to be able to listen, to be able to communicate well. It's also very important to be able to adapt and to think on your feet. And we are based within radiology departments in hospitals, but as I just said, that some walk-in centres do have X-ray departments that are attached to them. Oh, excuse me, sorry. So as radiographers, we work in, say, main departments, which involves seeing patients from clinics, seeing patients from wards, taking mobile machines up to patients where they're too poorly to come down to the ward, or they're too poorly to come down to the department to see us. We also rotate through dental hospitals, so we take pictures of teeth for trauma, illness, injury, patients with cancer. It really, really varies. Radiographers work in CT departments, they work in MRI departments, they work in ultrasound, nuclear medicine, interventional theatre, mammography, and paediatric hospitals. So the role is vast and really, really varied. And you can decide to go on and specialise if you choose to. You know, radiographers can go on to become sonographers. There's also breast screening for mammography, you know, looking at cancers that are too small to detect, or too small to feel. Sorry,
you can go back to university and do postgraduate degrees in things like CT and ultrasound, but also you can specialise to do some reporting. So when the radiographer takes the image, it's a radiologist who will then look at your image and say whether it's okay, whether there's a fracture, whether there's something going on. We do have some radiographers who specialise and go back to university, and then they can write the reports, and it's quite handy in A&E a lot of the time. You'll get the referrers coming down because we're the ones who look at the x-rays all the time. So they'll actually come to us to see if we think that the patient's done any damage to themselves, because we see them all the time. And we'll find that in most departments there'll be a few radiographers who are trained in reporting, and they will quite often be around the A&E department for any help and knowledge that they might be able to pass on.
So a tiny bit about the modalities. So ultrasound, that uses sound waves to look at body structures, and then you can that's an area that you can specialise into later on once you've had 3 years of qualification. 3 years of qualification.
3 years. Most people will associate ultrasound with looking at newborn babies. There's a lot more to it. In the Royal where we work, there's actually no neonatal ultrasonography, so they'll be looking at vascular, they'll be looking at musculoskeletal stuff. It can be quite specialised. I think you have to be qualified 3 years, and then you have to do 2 years training.
2 years of training.
Yeah.
Okay, so MRI uses strong magnetic fields and radio waves to produce images of the body. So again, this looks at patients who've had strokes, tissue damage, knee injuries. Lots of footballers are sent for things like MRI to look at injury and pathology, what's happening and why, what's the best way to manage that.
MRI is quite specialised with looking at ligaments and muscular injuries, which is why a lot of the footballers will go for them, or any infection. So if there's a problem with more muscular, you won't really see that on an X-ray or really a CT, so that's why they'll get sent for an MRI.
Okay, so mammography primarily is used to find breast cancer or breast cancer early, and then that uses X-ray tests to detect cancers that are too small to see and feel. And we have quite a big unit here at the Royal Hospital, and that covers mammography, and they do things like back scans, biopsies, and that again is, once you've qualified as a radiographer, they do take people who've not worked in a department. It's another interview, and that's a postgrad for, I think it's 18 months, and you study primarily radiography, and then you can become a breast mammographer.
There is scope, if you decided that you were interested in breast screening, there is scope to then specialise even further. So once you've trained and worked for a while in the breast unit doing your plain film mammography stuff, you can specialise in ultrasonography or biopsies. The radiographers are the ones who actually do all that now. So that's just another way that you can specialise there.
CT. So CT scans produce 3D detailed image structures of inside the body. Here at the Royal, we have, is it 3 or 3
Oh, we've
scanners?
got 3
We've
up
got
in the
4 now. Oh,
main
yeah,
and
we've got
1 in
right.
A&E.
Yeah, and then that looks a lot at well, that's absolutely everything. Everything comes through the door, from sinus infections to people who've had trauma heads where they, person's had a fall off a scooter, or they think it's, someone may have had a stroke. Full body scans.
If they've had a real bad fracture that's comminuted into many, many pieces, they'll CT scan it. One, to have a look at all the different pieces in a 3D image rather than 2 flat 2D images, but also to see if it's affecting any of the vessels, any of the nerves, any of the arteries or veins or anything like that.
Okay, and then there's also nuclear med. So this department uses radioactive isotopes, and these are injected into people, and they look to diagnose and treat. So the radiation that's emitted within the body from the isotopes looks to show how the area that's being examined is actually functioning. So this involves things like PET CT scans.
It's helpful in like tumours and stuff like that. Certain isotopes will go to certain areas. If you think that they've got a particular tumour, they'll give them the isotope that'll be drawn to it, and if there's one there, you'll see it and it'll highlight it for the scan, and it just helps then pinpoint where they need to assess the patient.
Okay, I can see there's loads of questions.
Should we do the PowerPoint images and then we'll go?
We were going to add a tiny bit at the end if anyone's got any questions about entry requirements for university and stuff, because we know that changes all the time. And the university have added something this year which is called contextual admissions, but we'll talk to you at the end about that.
So this is just a little PowerPoint just to show you some different images and things that we do. So let me have a little look. Let me see. So this is the first X-ray Joe was talking about, taken by Wilhelm Röntgen of his wife's hand. So these dark areas are his wife's fingers, and this bit here is his wife's ring. Now, if we compare that to an X-ray that we see now, you can see the difference in how things have progressed. So a little example here, this patient's coming in, they'll have had some high form of trauma direct to the leg, maybe an RTC, or they fell and landed on something, and they've got this fracture. So this is your femur, this is your knee, your patella, and this is your lower leg, so your tibia and fibula. So this is your femur, and they've got this nasty fracture which is quite displaced. So a femur is one of the most important bones in the body. It's without it, we won't be able to walk. It's our most weight-bearing bone within the body. So it's very important that this gets fixed and aligned properly. So what we do is we use this mobile image machine. So, Joe was saying we have a varied set of roles. This is actually a mobile image intensifier, and it's used in theatre. So we go up as part of the theatre examination. When they're in surgery, the doctors will ask us to X-ray, so if they can check they've aligned it properly, they can check that everything that they're doing will fix the body. So this takes live images, and then it will come out with this image here. So this is what's called an IM nail. So it means it just goes within the medulla, so within the bone, and it's aligned up nicely, and then you've got your pins either end just to help keep it in place, and then this will one, strengthen that weakened bone that's been fractured, but also make it heal in the correct place. So one of the things that's hot topic at the moment is obviously COVID-19. As radiographers, we were actually on the front line against COVID. So literally every person who came into hospital would come to X-ray for a chest X-ray. And most commonly, they wouldn't have a positive COVID diagnosis till they had their X-ray, because our X-rays were quicker than the tests that they were doing to confirm COVID-19. So this is your typical COVID-19 chest. You've got all these areas of density here. This is all the areas of infection. These are your ribs here, your clavicles with all your collarbones, your shoulders. This is your spine down the middle, and this is your heart here. So chest x-rays, they will look at chest for any chest pathologies, but we can also assess our heart for anything that we may have problem here. One of the things to remember is that not everything that we do is about broken bones. Some people decided to go swallowing a nice ring here. So we just need to track it, make sure that it is moving through the patient. This person's inhaled a nail. Quite common with people who are doing DIY, they'll put something in their mouth, then they'll cough, or they'll do something and the nail will go and it'll be inhaled. This person's decided to swallow 3 coins. You can see them here from different angles, which is why they look different. So this one is like facing us pretty much. This one's kind of on an angle, and this back one here is on its side, which is why it looks a lot thinner. It also looks like it's a smaller coin, maybe like a 50p. These are like 2p's, and this is probably a 5p piece here. And the last one here, so this patient's obviously not had a nice thing happen. They've got a stabbing in the head. So this is actually a section from a CT scan. So they'll be looking at how much this is penetrating into the skull. And then also as part of the scan, they'll be assessing the brain. So they'll be looking at where about in the brain it's actually affected. So is it affecting any of the arteries, has it hit any of the main nerves and then that'll give them an idea of how much damage that person's going to have. So that's our little quick slideshow. It was just to show you the different things that we can do. But what we'll do is we'll go through the questions, and then we can add a bit on the end about the university side of it and the training if we don't cover it in the questions. So how long does it train to be a radiographer? Traditionally, it takes 3 years, university degree. They are looking at doing apprenticeships in radiography, but they're not actually quite set up yet. So obviously things are always changing all the time. But the traditional route to be a radiographer is 3 years university degree. You need to have an enthusiasm in patient care. You need to have a little knowledge of science, because we do a lot of the physics side of how x-rays are produced, and we also need to have an interest in anatomy, because we need to make sure that we've got everything that we need on the image. So is there a limit on how many images you can take using radiography? So the answer to this is kind of. So I was talking about the legislations that we all have to follow with regard to radiation. So as part of each examination that we do, we have to log the amount of radiation that person has, and then this all goes in that person's record. So we do have a highlight if the patient's had an excessive amount of radiation, but it's all given on a basis of if the patient needs it, it's need over amount rather than, oh, you've had your limit for this year. So if you've got a patient who's coming in, they've got cancer and they need to have follow-up x-rays, that's fine. If a patient's coming in all the time with lots of tummy pain and every time you x-ray and there's not really anything happening, then it will become and highlighted that that patient needs to have a review by a consultant to make sure they actually need the radiation. And it won't be just that they can just have it every time they come in. So it's kind of, there is a limit if you are a frequent attender, but there's not really anything going on. But if there's really is a suspicion that there's something wrong, we would never say no, just because they've had a lot of radiation. It's kind of a balancing act, really.
So communication skills, someone's noted that communication skills are really important, and what other skills would you highlight? I would say it's really, really important to be empathetic, to put yourself in the patient's shoes, how they feel, what they're feeling when they come to hospital, because sometimes they can come across as quite angry. Often that's because they're frightened, they don't know what's going on and why. Once you explain to them what you're doing and the reason that you're doing it, then often you can kind of allay their fear and make them feel a lot better. Patients do come to us at times feeling really angry, upset and scared, but once we've looked after them and we've explained everything and where they're up to, they often leave and go back to see the doctor feeling really, really happy. So I think it's important to be empathetic. I think it's important to listen. It's also really, really important to be quite caring. What do you say?
I think another skill that's quite important is problem solving. So like Joe said, you've got these people coming in, they're really angry, they're upset, they're scared, and they're in a lot of pain. but at the same time, we have got to get that image in the correct position. We can't just take it any old way. All images are taken in set positions so that we can compare them and assess if there's anything wrong. So if you've got a patient who's doing that, you need to be caring and empathetic, like Joe said, but you need to be able to figure out the best way to get your image without distressing the patient more, but also making that dose of radiation worthwhile. You need to be able to give a diagnostic image. The question here is, how's the job changed since you qualified? Well, when I qualified many years ago,
We're still on playing film. We were on film, weren't we?
Still on film. So you see in the old movies and the TV shows where they actually hold up a film to a light box. That's what it was when I started. Whereas now we actually it's all on computer. We take an image and it comes straight up on the computer and it gets sent to a computer system for people to assess. We have all these little tools to assess your images on the computer, whereas we used to actually physically get a magnifying glass and hold it up to be able to zoom in on the images. We used to have to deal with a lot of chemicals for our processes to produce the images on the film. We don't have none of that anymore, so it's changed quite a lot since I started. What about you?
It's the same for me. So I used to dread putting your film through processing and then thinking, oh, please let there be something on it. Especially if you're in the dental hospital, you used to take your images, then you put them in a small wooden box, then you'd run outside your x-ray room, knock on the door, which was a little hole in the wall, and put your film through and pray that there was actually something on the image, because otherwise you'd have to start again.
It has helped with positioning and awkward patients, whereas we take an image now and we can correct it because the image comes up straight away and we know how to correct it. The patient will be done in 5 minutes.
Yeah, it's changed time massively. For
in the
patients, hasn't
past, you'd take an image and it'd take 10 minutes for your film to come out the
develop.
machine, and then your patient will have moved, so you have to then start again. So it's cut the time for the patients as well as ourselves quite a bit. So is your role so between clinical work, administration, record keeping? So after every clinical, we do our administration and record keeping. It only takes us 5 minutes at the most. So we literally just check our images is on the system, check them to the right patient, and everything's on them is correct. And then we fill on our what's called our CRIS program, which is our radiation information system. So we log the amount of radiation our patients had, and that's all we need to do. But we can split our time if we're specialized. So I spend half my time clinical, half my time reporting. Joe spends half her time clinical and then half her time doing training and stuff with the students. So there is different things that you can go into that will split your time. But if you go into radiography, you're going to be spending a lot of time clinical, and you'll find a lot of people will want to keep a lot of clinical time with their patients because that's what we go into it for. We don't go into it to be behind a desk and away from patients. So you'll find a lot of people, if you do administration or reporting, they will actually split it because they enjoy the patient contact. What made you decide to be a radiographer, Joe?
My son injured himself quite badly, and the radiographer who looked after him when he was unwell was absolutely amazing. Her name was Michelle Reed. She's absolutely gorgeous, such a lovely, lovely lady. And I asked her lots of questions about her job and why she decided to do it, and thought, I would love to be able to help people in this way. So I looked at courses, I went to shadow radiographers in community and hospitals. That's another thing we haven't touched upon. It's important to decide between therapeutic and diagnostic radiography, because when I asked at hospital about deciding on what type of radiography you would like to do, they said to me, you need to look at diagnostic, you also need to look at therapeutic, which is the treatment of cancer and cancer patients. I decided on diagnostic. And yeah, it was because of a lady I met really, and the care that she provided for one of my family, and how they were looked after. And I thought, if I can do something like that, then it would be a lovely thing to do, and I won't be going far wrong.
Mine's very similar. Actually, my little sister wasn't very well, and she was having regular scans and x-rays in all day, and I thought, oh, what a lovely way to be part of the healthcare service. Really, it's such an important role. Without a radiographer, the majority of patients wouldn't get a diagnosis and wouldn't be able to be treated. It's such an ever-changing role that you're always on your toes and everything's always changing, so you never get bored. So, and that leads on to our next one. Next one is, how do you keep your practice up to date? So we have regular CPD sessions. Jo actually is one of the leads in organising these. So it's not just about us. She organises talks from other modalities, doctors from A&E and nurse specialists who deal with like nutrition and stuff, because they lead into what x-rays we take. So it's all very important that we don't just stick to radiography. We need to understand our role within the wider healthcare spectrum. We have our union, the SOR, provides us with training. We have presentations, we have online things that we can do, don't we? And
Yeah,
teaching
yeah,
here,
so the SOR,
really.
CPD, it's on the SOR, yeah, teaching here.
The next two questions are linked together, really. So how are you protected from radioactive waves, and do you have to wear protective equipment and work in a special room? So yeah, the one thing that they found actually halts the radiation is lead. So we work in a room that's lead lined, so the doors have got lead in them, the walls have got lead in them. That not only protects us, it protects the general public outside of our x-ray room. We have, if you ever had an x-ray, you'll see that we have a glass screen, so obviously we can see what's going on in the room. They are lead lined as well. There is a line on the floor that we have to stand behind when we expose to make sure that we're not in the room. We wear badges, dose badges, and this takes an account of how much radiation dose we've had as part of our role within the last 2 months. And if this is particularly high, then it'll be investigated to understand why. We have to wear protective equipment. So say we're in theatre, like the machine that we showed you, we're actually in the room when the radiation's happening, or we go to a ward and we have to x-ray someone who's too sick to come down. We wear a lead gown. So it's basically a big overcoat that's lead lined, quite heavy. You wouldn't want to wear it all the time. They're quite uncomfortable, make you very warm, but they protect you. So, and we still have to wear our monitoring even underneath these to make sure. We also have people who are called RPSs, so they're radiation protective supervisors, and these are making sure that we're up to date with legislation, that make sure that like all the lead's like not cracked and there's no holes in it, so that we are always protective. And then these go on to investigate if we have a high level of radiation on our badge. So we are very well protected, really. It's a physical role. You must be on your feet a lot.
Yeah. We are on our feet a lot constantly. We rarely sit down. From time to time, if you go to theatre and you're in a long case, then you may get the opportunity to have a stool. The surgeon will ask you to get a stool and sit down. That's because you'll be wearing protective clothing beneath your lead gown, a hat, a mask, a lead collar shield. And because it is really, really warm, from time to time, people faint. Not very often. Normally because they haven't had breakfast and they've rushed to get here in the morning. So it's important to look after yourself. But yeah, it is a really physical role, and you are pretty much on your feet all day, aren't you?
It's not just the being on your feet, it's also the fact that we have to physically move our patients. So, people who come in, they can't necessarily move. We need to do a chest x-ray, the x-ray board needs to go behind their back if they can't move. Your patient can't sit up, it's up to the radiographer to be able to help them sit up. So we do a lot of manual handling in our job. We have to slide patients from beds to our x-ray table. We have to move them forward, and then we have to go in, position the patient, then run around behind the screen so we're protected to press the button. So we do a lot of steps going in and out without all our manual handling. We always make sure that we count our steps to see how much we've done. So let's see. What are the entry requirements for diagnostic radiographer? So you've got all that.
Yeah, so because it changes it's changing regularly at the moment on account of COVID, and the way people like yourselves have been examined this year and the results that have been given out. So the entry requirements generally are, so GCSEs you will need 5, and they will be grades A to C, or now I think that's 5 to 9, and those must include English, maths, and at least a science. A levels also are accepted, and a science has to have been taken at A2, and you need a pass for that. BTEC nationals are considered, and they also have to include a science. The equivalent certificates in Scottish and Irish qualifications are you are allowed to use those access. So students who sometimes didn't do as well as they might have done in A levels, or they've done A levels but they didn't take A level as a science, so you can go back and do an access course, which is also the equivalent of a year zero course, which is available via the university. And those are, I think you need 60 credits at level 3 for that. This year though, and I think it will probably continue for the next couple of years, so Liverpool University is offering something to applicants who've experienced barriers to their education, and it's eligible for UK students. So this is called contextual admissions, and what's being considered is things that like so one of the contextual admissions is based on postcode areas. So this would depend on how many people have applied from a specific area. So say, for instance, lots and lots of people apply from L25, which is considered quite an affluent area, whilst not a lot of people may have applied from, say, Liverpool 4, which is considered to be a less affluent area. So they would look at that and take that into account and look at how they approve their places for the university course. They're also doing something this year as well called Care Experience. So this is also geared towards students or youngsters who at some point in their lives have been in care or in the care of the local authority due to no circumstances of their own. They've just found themselves as being cared for by the local authority, and then the university will use that as a sort of mitigating circumstance in order to provide you with a place on the course.
Okay, so health and safety is key, how to keep up to date with new legislation rules. So with regards to our radiation ones, the RPSs that we talked about before, they will be in charge of going through the new legislation, making sure that our departments are all up to date with the new legislation, and then we'll all have training, in-house training. And the same with all the other ones that move, really. It'll be our CPD sessions, or it'll get disseminated down from senior staff to junior staff, and it's all really in-house. We'll also get information from our society, our union, the Society of Radiographers. They will disseminate any new legislation changes, so you're always being given the opportunity to know what's happening.
So our individuals are going to specialism sponsored to qualify. So some courses are covered, aren't they, by the trust?
So when you first start, can you still get an NHS bursary?
Yeah, it's changed now. So some students are entitled towards, I think it's £5,000 a year towards your studies when you're at university and your personal circumstances. So it depends on if you are part of a single parent family, if both mum and dad work, and the money that they gain collectively isn't over a certain amount, then you do have the advantage that you may not have to pay it back. I think our students this year have been given a payment with regard to COVID. I'm not quite sure how much that was, because a couple of them said different amounts, but they were allocated that and they didn't have to pay that back. They were given that as part of their study. It's like a grant that they could keep, because some people obviously don't have laptops, so it would allow them to have laptop access at home, accessibility to books, in order to support them studying, because although they've been able to come into practice and they've been able to study with us and they've had the practical aspect of their university course, they've not been going into university, and some of their courses have been via Zoom or Microsoft Teams. So it was to support that aspect of their study. Whilst at home, they could use the money maybe towards paying for internet if they didn't have that facility and things like that.
With regards to people who are already qualified, who go on to specialise in a particular area, so for example, ultrasound or reporting or CT, some of the jobs will be in-house training. So if you go to CT from here, you'll be going to a different banding. So you go from a band 5 to band 6, and then you'll get on the job training. So it's not like you get money to do it, but you're getting your wage while you're in work. So it's not like you're leaving work to go do it. With regard to, for me, when I went to university to do my postgrad, I didn't get any extra money for doing it, but I was doing it during work time. I got time off to study, and I got time off to attend uni and for my exams and stuff. So I wasn't losing any money, but I didn't get any extra money.
The other benefit of that is that where people maybe worry about the fees being paid
Oh
and
yeah,
the
the fees are
affordability, the
paid.
fees are covered by the trust that you work for.
Yeah.
It's the same for things like mammography, and also, as Jade just said, for ultrasound, the fees are paid for by the trust where you're working. So as Jade says, you'll still be able to go away and study, but you won't have the added worry of the finances and how you're going to manage that and how you're going to look after yourselves. And that's all sort of looked after by the trust. What's the most surprising X-ray image you've seen?
Well, people like to put things in any type of hole that they have on their body. So I'm sure you can imagine, but we have lots of people coming in swallowing things
falling on
and certain
things.
things in the ears and certain things in the nose, any other hole that you
Hilarious.
can think of. Yeah. Well, the main skills you'll need, I think we've kind of covered that. So you need to be caring, compassionate. You need to be good at problem solving. You need to have some form of logical brain. So you need to be able to understand the basic physics, and you need to have good memory. 'Cause the amount of X-rays that we do, and every single one has a different position, and there's 3 or 4 different positions for each one. It's a lot of things that you need to remember. Is it possible to do some volunteering? You can come in, you need to apply, and we can set up times for people to come and shadow.
Yeah, you have to go by the clinical tutor, don't you? Her name is Rose Edwards. So if Sharon needs any information regarding that at the end, we can provide that for people who are considering volunteering. You can also volunteer in community settings. Rose again sorts that out. It's good to volunteer. It's good to see what we do through the day, because sometimes you think you have an idea of what you do, of what we do, but because it's so different. I think
I would
I
recommend
volunteered. I would definitely recommend volunteering so you can see what happens and why.
when I qualified many years ago, it was part of some of the universities thing that you actually had to have a day volunteering, and it's signed off before they'd even interview you.
Yeah, because you had to talk about during the interview experience, you would have to talk about what you saw in the department, what examinations you took part in, what happened and why. You had to talk about that quite confidently. I think because people think they can say they've watched something like
I do
Casualty on TV and
think it's a very rewarding job, but it's not for everyone. So I think it's very important that, you know, if you are seriously looking at it and thinking about it, that you come down and see us. Everyone's always very helpful and like happy to share what their experiences and what brought them into radiography. And you'll find that most radiography departments, the ones I've worked in, they're always very sociable. Everyone's always very happy to talk and very friendly and helpful. And I think just to make sure that it is the right job for you, because it's, you know, it's 3 years of university and all your fees and stuff, and then it's a long time to be studying. You need to be sure it's the right job for you. But I personally think it's a very rewarding and it's very interesting and it doesn't ever get boring. As you can imagine from our question of the most surprising X-ray image, it can be quite interesting some days. So because we work in so many specialities, we never get stuck in one
it
place.
changes.
So, but yeah, I would recommend just to make sure it's the right job for you, because like Joe said, we are open 365 24/7. So there's always someone here. And last question. Do you find it hard to deal with when you discover patients are life-threatening issue forms? Yes, I personally do.
I think it is hard, but I think the most important thing with the likes of that is that everything is done in a timely fashion in order to make sure things are dealt with quickly for the patient. The patient is at the forefront of it. You think, right, what can we do now to make this move really quickly to make sure they're treated well, and everything is done.
I think it can be, especially when you got like someone really nice and they come in and you see something on the image, and then you're like, it can take you back, but at the same time, you'll have that person come back in 3 months' time and you'll see how much they've improved and how much they've progressed. And it's a really rewarding job in that sense that from what you've done and your imaging has helped to get this person sorted, and now they're like really
on track to where
they were. Yeah, it can be very rewarding.
I think that's the thing, isn't it?
And the majority of times it isn't like really sad. Most of the time it's
it's things that can be, yeah,
nice.
it's lovely, isn't it? Things that can be resolved. But the thing with
And-
that is this, it's just that everything is done quickly so that we can do the best for them at the time. Isn't it?
And everyone
Think-
works well, so nice together as a team. It's
Good
a
to be a
nice
team
place to
player.
work.
Important to be a team player, but also also important because on nights there's just two of you, because we do night shifts. So to be able to think on your feet. But we are part of a really, really lovely team, aren't we? We really are. We're really, really lucky because we all really look after each other. don't
Quite
we?
a small profession as well, so there's not that many of us around. So you'll find that your team will join together and look after each other when needed. But yeah, any other questions or we sorted? I think you're on mute, sorry.
Can I just say that if you are interested in work experience in the radiology department, if you email me for an application form, and then I can send that on to Rose then to arrange placement for you.
Is that okay,
Okay.
Sharon?
Okay. Thank you for your time. I think Kath, you were trying to say something, but you're on mute, so we didn't quite catch.
Sorry, Sharon. I was just saying, would it be okay to put your email in the chat so students
Yeah.
got that, please?
Yeah, I'll do that now.
I was just saying what a fantastic session that was. It was so informative. Your commitment to the role absolutely shines through, and I think myself, I've learned so much from the session today. Some shocking images, and I'm sure that your job, it's obvious that no 2 days are the same, but you show your commitment to the role. So fantastic session, and thank you so much. And
Thank you,
thanks
that's nice
to all
to
the
hear.
So
speakers
thanks for having
today.
us.
Thank you, Jo. Thank you, Jade.
All right, thanks so
No
much.
worries.
Nice to see you again.
And
Bye.
you.
Oh,
you.
take care. Thanks for your
Thank you.
help.
So
Bye.
that concludes our session for today. We've got 3 more days of activities through Creating Careers Moving On. So if you're able to tune into any of those, you're very welcome. Thank you so much to Sharon for organising today, and to all the speakers. We've had a great variety of speakers. They've all been brilliant. So thank you all very much. We've overrun a little bit, but it was so worthwhile. Thank you, Sharon. Do you want to say anything, or?
I would just like to say that I can provide a certificate for today's session. So if I've just put my email address in the chat box. So if you'd like a certificate, then just to send me an email and I'll send you a certificate back. And thank you for joining us. Thank you for joining us
Thanks so
today.
much. Bye-bye.
Thank you. Bye.